Thank you, Mr. Chairman, for your kind introduction. A very good afternoon to everyone. First of all, I would like to thank the organizing committee for inviting me to take part at this meeting. In this talk, I shall provide some updates on epidemiology, clinical manifestations, case management, and prevention and control of hand-foot-mouth disease. Hand-foot-mouth disease is a viral skin infection that usually affects children aged 5 years and below. The name of this disease provides a good description of the salient features of the condition. It is characterized by the development of macular-papular or papular-vesicular rash on the palms and soles, as well as mouth ulcers in affected persons. At times, especially in younger children, the rash may involve knee, elbow, or buttocks. The infection is most commonly caused by members of species A enteroviruses such as EV71, CA16, and several others such as CA6, 8, or 10. When we talk about hand-foot-mouth disease, it's important to keep in mind that the appearance of the rash or ulcers may not always appear together at the same time and not in a specific order. On the other hand, there's a closely related condition called herpangina that involves multiple painful oral ulcers without skin rash. It is also caused by members of species A enteroviruses. Therefore, it is not uncommon to have a child with hand-foot-mouth disease diagnosed as having herpangina at times because oral ulcers was the only lesion present at the time of the medical consultations. Hand-foot-mouth disease was first described in the late 1950s in Canada and UK. Prior to 1997, it has always been considered a rather benign, self-limiting condition. The main clinical problems that may arise from the infections are painful oral ulcers that can affect oral intake, which may lead to dehydration in some children. However, such perception has changed dramatically in the late 1990s, when virologists and pediatricians were surprised by a cluster of sudden death among children who had hand-foot-mouth disease in Malaysia in 1997 and a year later in Taiwan in 1998. EV71 was found to be the primary causative agent of these unusual clusters of deaths. Please allow me to show you a case summary of one of our first fatal cases that describe the clinical presentations of fatal EV71 associated hand-foot-mouth disease. As you could see from the slide, this is about a 2-year-old girl who first saw a GP for fever and skin rash, painful oral ulcers, and poor oral intake. Her parents thought that she was still well then. She could still play, although not as active as her usual self. She was treated symptomatically with intramuscular injection and was diagnosed as having hand-foot-mouth disease. On subsequent 2 days, she did not get better. On the 4th day, she saw another GP and who thought that she required hospitalization for intravenous rehydration treatment. However, 30 minutes later, she was found on arrival at the accident emergency department in a severe respiratory distress, poorly perfused with the severe tachycardia. She required immediate intubation and her cardiac function was rather poor on echocardiogram. She died 8 hours later despite intensive care treatment. So as you could see, at the early stage of the most severe form of EV71 associated hand-foot-mouth disease, the presentation could be rather subtle and non-specific, yet the disease progression is very rapid and fulminant. Early recognition and intervention is the key to a better clinical outcome. Here, we have a rather intriguing clinical syndrome. It starts with a skin infection that rapidly followed by signs of the brainstem encephalitis and very quickly followed by potentially lethal severe cardiac impairment and acute pulmonary edema. All these occur within 3 to 4 days after the onset of skin rash. Following the outbreaks in Malaysia and Taiwan, the perception towards hand-foot-mouth disease, especially among the public and the healthcare workers, has changed from a benign self-limiting to a potentially fatal skin infection. Indeed, the Malaysia 1997 epidemic was the starting point of cyclical massive epidemics involving hundreds and thousands of children with hundreds of deaths in Asia-Pacific region. This slide shows us that some countries in Asia have been experiencing recurrent epidemics over the past 20 years or so. The scale and the recurrent nature of the outbreaks has prompted many countries in Asia set up surveillance programs on hand-foot-mouth disease. In some countries, the health authorities have classified hand-foot-mouth disease a notifiable disease by law. The survivors of brainstem encephalitis are often affected by a host of neurodevelopmental sequelae. The disabilities are not confined to neurological or respiratory system per se. Many other domains of childhood developments are also significantly affected. They are serious morbidities and require long-term rehabilitation, which may not be readily available in many low and middle-income countries. Indeed, with the success of polio eradication program in Asia, EV71 has become the most important etiology for non-polio enteroviral CNS infection in Asia. Because of its link to sudden death, hand-foot-mouth disease has become one of the few major public health issues that could trigger a lot of public anxiety as well as attract media attention in the region. In addition, hand-foot-mouth disease has also posed major economical burden to low and middle-income countries. During a large outbreak of hand-foot-mouth disease in Vietnam in 2016 and 17, the estimated cost for a case of hand-foot-mouth disease may range from 100 to 1300 US dollar, which corresponded to about 1 times to more than 9 times of average monthly income per capita for Vietnam in 2016. Over the past 10 to 12 years, we have observed a shift in the epidemiology of hand-foot-mouth disease in terms of its geographical distribution and viral etiology. Between 1997 and 2008, hand-foot-mouth epidemics were largely observed in Asia, and EV71 was the primary causative agent. Since 2009, countries in Asia, Europe, and North America have experienced repeated outbreaks of hand-foot-mouth disease caused by CA6. Indeed, CA6 has emerged to become the most important cause of hand-foot-mouth disease in China between 2007 and 2017, as shown on the slide. Recent CA6 hand-foot-mouth disease has unique clinical features when compared to that caused by EV71 or CA16. Apart from typical or classical presentation of hand-foot-mouth disease, recent CA6 has a broad range of skin manifestation, which mimics some well-recognized dermatological entities that I shall talk more in the next few slides. It affects adults more often than in the case of EV71 or CA16, but rarely causes severe CNS infection. Viral sequencing work of Peter Simmons and colleagues in Edinburgh has shown that virus genetic recombination may be a plausible explanation for the clinical features that we observed so far. When CA6 affects individuals with underlying skin eczema, it could result in widespread skin lesions, resemble that caused by herpes simplex virus infection. Erythema multiforme-like lesions have been observed too. CA6 can also cause very large bullous lesions, as seen on the right panel of the slides. These types of lesions is usually seen in infected infants and may become hemorrhagic in some cases. Other presentations include chickenpox-like lesions, vasculitis, and others. The myriad of the skin manifestation mimicking other skin pathologies has posed a diagnostic challenge to pediatricians and dermatologists. Perhaps the distributions of the lesion may offer a useful diagnostic clue to the viral etiology. For example, its predilections to areas around the mouth or skin areas that previously injured by sunlight or irritants could be a useful clue when doctors are presented with cases of hand-foot-mouth disease at their clinics. In this photo, the skin lesions were largely confined within a well-demarcated area on the right forearm of a child who had a cast earlier. Another unique clinical features observed in the recent CA6 outbreaks has been its close association with skin and nail changes during the convalescence period. I would like to show you a series of photos taken from a case of adult CA6 hand-foot-mouth disease. The photos on the slide show you the typical skin lesion on the palms and sole that appear 4 days after the exposure. These lesions took about 6 to 7 days to resolve completely. And on the day 8 of the disease onset, the skin on the palm and soles start to peel. 4 weeks after the disease onset, the clinical signs of the nail bed separations and a burr lines become apparent. And here is the appearance of the nails a year later. The delayed nail changes occur around 4 to 6 weeks after the onset of the skin rashes, according to a meta-analysis conducted by Giles and colleagues. It has been found in about 30% of the CA6 hand-foot-mouth disease cases. Fingers seems to be more often affected and could involve any number of nails. Spontaneous full recovery seems to be the rule, although the exact mechanisms of nail changes remains uncertain. Just like other members of species A enteroviruses, such as CA10, 16, CA6 can also cause CNS infection, as shown on the table here. Fortunately, it is rather uncommon. The mechanisms of most severe form of hand-foot-mouth disease is still not very well understood. Based on clinical, laboratory, and animal studies so far, cytokine storm and sympathetic hyperactivity are the two major disease processes that may contribute to the pathogenesis of the potentially fatal neurocutaneous syndrome. Although we have not fully understood the pathogenesis and other determinants of severe hand-foot-mouth disease, the natural history of hand-foot-mouth disease that complicated by brainstem encephalitis and pulmonary edema has been very well defined through well-conducted clinical studies during the early outbreaks in Asia. The presentation of hand-foot-mouth disease with CNS involvement is rather stereotypic. Started with mucocutaneous involvement, the disease next affects the brainstem and results in autonomic dysfunction, which later followed by acute severe cardiorespiratory failure. It is important to note that autonomic dysfunction and subsequent cardiorespiratory failure is always preceded by CNS involvement. However, not all cases with CNS involvement will always develop autonomic dysfunction and acute cardiorespiratory collapse. A well-conducted clinical studies in Vietnam has shown that about 6% of cases with CNS involvement may develop progressive disease, and about 10% with autonomic dysfunction may develop fulminant heart failure. Duration and severity of fever, as well as lethargy, had been identified as important clinical predictors of CNS involvement during the earlier epidemics in Sarawak and Taiwan. These clinical predictors have also been observed in subsequent epidemics in other parts of Asia. Similarly, tachycardia, hypertension, tachypnea, hyperglycemia that were found useful in identifying cases with impending acute cardiac impairment have also been confirmed by other groups in different parts of Asia. As far as clinical management of hand-foot-mouth disease is concerned, there is no specific antiviral treatment for severe hand-foot-mouth disease. The management is largely supportive in nature, and what's more important is the communications and education with the parents, childcare providers, and the teachers about the warning signs of the hand-foot-mouth disease. Besides general supportive treatment, several therapeutic approaches have been used to manage severe hand-foot-mouth disease complicated by brainstem encephalitis. Intravenous immunoglobulin or IVIG have been used widely in Asia based on anecdotal practice. With a clinical belief that timely use of IVIG at early stage of autonomic dysfunction, IVIG may stop the clinical disease progressions to frank cardiorespiratory failure. Although there's an improvement in case fatality rate that documented through observational studies in Taiwan, Malaysia, and Vietnam, there's a need to have a well-conducted randomized controlled trial to validate the clinical observation so far. Hyperimmune sera infusion has also been tried in Thailand with some success recently. This may indicate that viral neutralization may be an important mechanism of action in immunotherapy of hand-foot-mouth disease with brainstem encephalitis. While immunoglobulin is used empirically with the aim to stop disease progression, continuous hemofiltration has been used as a rescue therapy in children who develop fulminant cardiac failure in Vietnam and China. This novel intervention has been used widely in Vietnam in 2011 with apparent positive results when the country experienced one of the largest EV71 epidemic in her history. However, so far the published report on the application of this intervention have confined to case reports or series. Just like the case in IVIG or immunoglobulin, a well-designed prospective studies based on a large population is warranted to explore the role and the position of hemofiltration in severe hand-foot-mouth disease. Although there's still no specific antiviral treatment for hand-foot-mouth disease, effective EV71 vaccine is now available. There is a total of 3 and all are produced in China. It is currently only available to the domestic market in China. All the 3 are formalin inactivated and contains alum adjuvant. It is important to note that there is no cross protections to CA6, 10 or 16. Therefore, a multivalent hand-foot-mouth disease vaccine that also cover other enteroviruses such as CA6, 10 and 16 is the way forward in prevention and control of hand-foot-mouth disease. So, meanwhile, non-pharmaceutical measures such as personal hygiene, hand washing, decontamination of surfaces, and social distancing remains the essential public health tools in the control of hand-foot-mouth disease transmission. One last point I would like to highlight is about hand hygiene. As we know, alcohol-based hand disinfectants contains about or around 70% alcohol concentration. These hand sanitizer or disinfectants have a broad spectrum bactericidal activity. They are used extensively in healthcare setting and now also widely promoted in the community as a control measure to contain COVID-19 pandemic. It is important to be aware that antiviral activities of 70% alcohol concentration has been shown to be poor against non-enveloped enteroviruses such as EV71. Although higher concentrations of alcohol such as 95% ethanol may be effective, it is still unable to fully inactivate the virus. Moreover, regular use of very high concentration of alcohol can cause skin irritations or contact dermatitis, which may not be well accepted by many end users. Therefore, hand hygiene with alcohol-based hand sanitizers alone is not recommended in prevention of EV71 transmission. Finally, I would like to end here by saying hand-foot-mouth disease is no longer an entirely benign condition, as it may be associated with severe neurological and systemic complications. The epidemiology of hand-foot-mouth disease is evolving with emerging pathogens that continue to cause significant disease. Although a better understanding of the disease has led to a lower case fatality rate, but not always a better outcome. Similarly, even EV71 vaccines are now available, it does not confer cross protection against other enteroviruses. Therefore, a multivalent hand-foot-mouth disease vaccine is still required. Until such time, conventional public health measures, including hand washing with soap and water, remain essential tools in the control of the disease. I would like to thank everyone for your kind attention. Thank you.